colleges, and our two medical colleges, the Women Medical College and the Azad Jammu Kashmir Medical College, Muzaffarabad. I thank Dr. Amjad Taqweem Saab for being our speaker today. He's a renowned physician of KPK, a gold medalist. He has FCPS MRCP from Ireland. At the moment, he is CEO of HealthNet Hospital and HOD of Medicine in the Park International Medical College. Prior to it, he was the professor of medicine in LRH, which he resigned. And we really lost a very good physician in the government sector. But again, he's still in KPK, so we are thankful to Almighty Allah for his expertise. Dr. Amjad is really an asset for us. Now I will request Dr. Rashid for a few verses of the Holy Quran. Rashid Saab.
Yes, Jazakallah. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم إذ يوحي ربك إلى الملائكة أني معكم فثبتوا الذين آمنوا في قلوب الذين كفروا الرعب فاضربوا فوق الأعناق واضربوا منهم كل بنان. तर्जुमा शुरू अल्लाह के नाम से जो निहायत मेहरबान रहने वाला है। वक्त जब तुम्हारा रब वही के जरिए हुक्म दे रहा था कि मैं तुम्हारे साथ हूँ, मोमिनों के कदम जमाओ, फिर तुम गर्दनों के ऊपर वार करो और इनकी उंगलियों के हर जोड़ पर ज़रब लगाओ। और एक छोटी सी हदीस सही बुखारी की बुक 24 की है, हर वो दिन जिसमें सूरज तुलू हो उसमें इंसान के तमाम जोड़ों पर सदका वाजिब होता है जिनकी तादाद 360 है। और फिर आगे सदके की तरीके बता दिए गए हैं। सदक़ल्लाहुल अज़ीम।
Jazakallah khair. Thank you, Rashid Saab. Now to Dr. Amjad Taqweem Saab for a very interesting topic about experience with biologics and the drug tofacintinib. Ji, Dr. Amjad Saab.
Assalamu alaikum. Welcome to everyone. I'm already introduced, so I will just say Professor Amjad Taqweem. If you have any problem in hearing me, you can interrupt me in the middle. I will have my picture at the corner, and if you don't like my face, you can always ask me to make the video. No need to further introduction, so I will go with the biological agent. There are no kids on the block, so everybody is using it. We as a rheumatologist are also using it, but everybody is in neurology, cardiology, gastroenterology, nephrology, every specialty of medicine now is filled with a biological agent. There is a few words about rheumatoid, otherwise we won't know what we are doing. So rheumatoid arthritis is a peripheral, symmetric, polyarthritis, autoimmune of unknown cause with ineffective therapy. Now each of these words carries a lot of meaning. First, it is peripheral, means the small joints of the hands and feet have to be involved to make the diagnosis of rheumatoid arthritis. If the small joints are not involved, there is 99% chance that your diagnosis is wrong. So much so that if there are 10 large joints involved, but not a single small joint involved, then you are probably wrong in making the diagnosis of rheumatoid arthritis. So the first thing to know is it's peripheral. Second, it is symmetric. Symmetric means it can involve both sides. Symmetry from rheumatology point of view is a bit different from physiology or anatomy point of view. Like all metacarpophalangeal joints, although there are 10, in each hand there are 5. From symmetry point of view, we call them one. So if there is a metacarpophalangeal joint involved, only one in the right hand and all the 5 in the left hand, this is symmetry. You got my point. So the number doesn't matter. The joints involvement. If there are small joints, one is involved on one and 3 are involved on another, it is still symmetric. So it has to be peripheral, it has to be symmetric, and it has to be synovitis, because the rheumatoid arthritis doesn't involve any other portion of the joint. Like in back, we don't have any synovial joint, so rheumatoid arthritis will not involve the back. But the cervical spine, the larynx, and even the ossicles of the ear are synovial joint, so rheumatoid arthritis can involve them. So it's peripheral, symmetric, synovitis. It's autoimmune. Your own body attacks you. Why it attacks you was just like we have a physiologist, so I will quote the Guyton. When the Guyton says we don't know the cause, so he will write then 20 pages. That is the common thing. There are then 100 theories, none of them is correct. So the end result is, for some unknown reason, your body attacks your synovial joint with cytokines, lymphokines, and so on. And that results in a destruction of the synovial joint. What we want to do is control that synovitis, prevent that destruction, and a lot of therapies are present, and all of them, or majority of them, are partially or ineffective. I generally teach my students very simply that rheumatoid arthritis is SAID and SAID, DMARDS, PPI. I by nature am a poet, so I ended up in a medical profession, rightly or wrongly. So I just add a few tweaks of my own here and there. SAID means steroidal anti-inflammatory drug, and SAID is non-steroidal. DMARDs are disease-modifying anti-rheumatic drugs, and PPI, of course, all of them destroy the stomach, so you have to get something, add something to protect the stomach from. Steroids are the cornerstone of therapy, and that has to be remembered. If you are treating asthma without steroid, you are killing the patient. The commonest cause of death in asthma is not using steroids. And similarly, the commonest cause of deformity in rheumatoid arthritis is not using steroids when indicated. Steroids are like a knife. You can cut a throat with it, or you can cut a fruit and vegetable with it. So it depends on the hand, not on the knife. If you use it properly, they're the most effective anti-rheumatic drugs available. And if your rheumatoid arthritis is controlled without use of steroids at all, because we usually give it for a year, then taper it off, then again, most probably your diagnosis is wrong. Non-steroidal anti-inflammatory drugs are the painkiller. The patient come to you for treatment of pain. If you don't treat their pain, you do nothing. Now, NSAIDs are cardiotoxic, nephrotoxic, gastrotoxic. There may be a lot, but they keep you mobile and functional. If you are immobile and if you are non-functional, then probably your doctor is useless. So that's, you always have a fight with the cardiologist, because they will stop the drug that this is cardiotoxic. The patient will come then again, we will care. So I always ask them, is sitting in a wheelchair not cardiotoxic? Because practically it's not possible. If you are not using SAID and NSAIDs, so how will you control the pain? And if the patient is all inflamed, how can he move? The third is the disease-modifying anti-rheumatic drugs. So these are the basic cornerstone of drug, but it has to be remembered, they are not pain killers. Their job is to prevent deformity, control synovitis. So over the period of 6 months, you will not use NSAIDs or SAIDs to control the disease. And if over the period of 6 months, they're ineffective, then you change the DMARD to another one. PPI is not the topic of discussion, so we will leave it there. Biological DMARDs, just like with what we do in medicine, when a new drug comes, it's a new kid on the block, we claim a lot. we deliver little, we do a lot of harm, and we earn a lot of money to control pain. Believe me, there is a lot of money in biological agent, and the multi-billionaires have become more multi-billionaires with use of biological DMARDS. Whether they are required or not, whether they are alone sufficient or not, that's a separate topic of discussion. If I am allowed, I will do some comparison some other day. Let's go to a very interesting fact: resistant rheumatoid arthritis, which will not give a response to any therapy and remain progressive, no matter what you do with them. They will go on and become deformed and crippled and bedridden. This percentage was 5% when we had no medicine, even the painkillers were not available. And they were actually using salicylic acid, not acetyl salicylic acid, to treat the pain, and that will cause a lot of gastric erosion. Even then, resistant rheumatoid arthritis was 5%. Then we had ancient DMARDS like gold, penicillamine, which we don't use anymore. And resistance DMARDS were still 5%. Then we got the gold standard DMARDS like methotrexate, leflunomide, cilazodine, hydroxychloroquine. But the resistant rheumatoid arthritis is still 5%. And now we have got biological DMARDS, which are very, very expensive, very fancy, very interesting way to make them. And the resistant rheumatoid arthritis is still 5%. So I will say in a way we achieved a lot because everything has inflated, but rheumatoid arthritis, we protected from inflation and it still remains 5%. Synthetic DMARDS, they are anyway the first line, they are cheap, they are freely available, they are non-injectable oral therapies. They are called synthetic because they are synthesized ineffective. Multiple actions, multiple side effects. We will just concentrate on methotrexate and leflunomide because these are the two most important or effective therapies. Cilazodine and hydroxychloroquine are important only because they are not contraindicated in pregnancy. Otherwise, I don't think they are of any superiority over leflunomide or methotrexate. Methotrexate inhibit purine synthesis, leflunomide inhibit pyrimidine synthesis. I will not go into detail of that because it will become too long. But the important thing, there is a big difference between the lymphocyte and the rest of the body. The rest of the body has two methods to make DNA. One is de novo, it makes a new one from the freshly available material. And one is salvage pathway. Like it has the denatured DNA present from before, it takes purine from one, phosphate from other, and DNA and sugar from other, and so on, and combine them all together from the available store and makes a DNA. This is called salvage method. Normal cell uses both. Salvage means whatever material was left over, it was present in the store. So the spare parts are available, they assemble the spare part, makes a new one. This is salvage pathway. And the other is de novo. Activated lymphocyte have only de novo pathway. So if you stop the de novo pathway, you can stop the action of lymphocyte, but the other cell will remain active. So that's why we use methotrexate and leflunomide to stop the activated lymphocyte without harming other cell. We still do harm the other cell, but less than the lymphocyte. And as you know, immunity is lymphocyte. So if you block lymphocytes, you will block the immune response. And the other synthetic are target-specific JAK inhibitor like tofacintinib. Tofacintinib we will discuss. It's both synthetic and it's both biological. Synthetic because it's made by chemical process, and biological because its action resembles the biological agents. Now, biological DMARDS in general, they are made by genetic engineering. They are all proteins. So naturally, you have to give them parentally because if you give protein orally, the gastric acid will destroy it. They block the immune system at different sites. So they are classified accordingly. Here I will just summarize the immune system in a very short way so that we know what we are doing with the biological agent. And as I said, I usually give my own tweaks here and there. So I will very simply tell you that antigen presenting cell like macrophage, dendritic, etc., present the antigen to T cell. T cell then requests the B cells and the macrophages, which releases lymphokines and cytokines. And these lymphokines and cytokines, the actual proliferation skins are somehow like kines. Lymphokines and cytokines, then they cause the inflammation by damaging the target organ. So it's antigen presenting cells to T, T requests to B, B and macrophage then releases chemicals, and those chemicals then cause the damage. So if you stop T, B or chemicals, you can stop the damage. The request between all these things in an immune system happens through chemicals. These chemicals are called cyto for cell, kines for movement. So cytokines, these are the chemicals through which the message is transferred in an immune system from one to another. You can call it SMS, or you can call it old, the pigeon carrying the message, but these messages are carried from one immune cell to another immune cell via the help of cytokines. If it is between the lymphocyte, it is called lymphokines. These cytokines are then of different types. We, as an immunologist, deal with the tumor necrotic factor, interleukin-1, interleukin-6, interleukin-17. But other than these, there are interferons and there are the hemopoietic growth factors. The hemopoietic growth factors are important in hematological malignancies, and the interferons are important in the treatment of the hepatitis, but we are not concerned with that, so I will limit myself to interleukin-1, 6, 17, and anti-TNF, T and B. These are what a rheumatologist deal with. Now what happens is T request B and macrophage, which causes release of the cytokines. Cytokines are low molecular weight substances. They can act at a different site. Multiple cytokines can act on one site. That is called redundancy. Like TNF and interleukins both act on a synovial joint and destroy the synovial joint. Or they can act at multiple sites. Either way, you have to block them if you want to control the inflammation. The stages of rheumatoid arthritis is just plain synovitis. Each joint, there is an articular surface covered by articular cartilage. In periphery, there is a capsule. Capsule is lined with synovium. That synovium does not go to cover the articular surface. So this is bone, that's the articular surface. Synovium is here, but it does not cover the articular cartilage. And that gives nutrition to the synovial fluid, and the synovial fluid then gives nutrition to the cartilage. Initially, there is just synovitis. Then the synovium becomes inflamed and spread over the articular surface of the bone. Then it is called pannus. An inflamed synovium which covers the articular surface of the bone is called pannus. Then this pannus causes damage, which first result in fibrous ankylosing. Ankylosis means fusion, or bone ankylosis. In stage 1 and 2, you have a chance of remission. Once there is ankylosis, your chance is at damage control. So our best time to attack rheumatoid arthritis is when you have got stage 1 and 2. So this is when you attack it with everything you have got. As we said, biological DMARDs are according to the site of action. They are divided. They act on T cell, B cell, and the cytokines. And according to these, their classification is. And their naming is also very interesting, so I will talk on that also. The T cell A beta sept. When you get a sept in the end, it means it's a fusion protein. So A beta sept, I am hearing an echo. Somebody has, please.
Rashid Saab, I think it's your mic. Please
वो ठीक कर दिया, वो नेट नहीं आ रहा था, स्विच ओवर किया तो वो ठीक कर दिया मैंने.
ठीक है, fine, please. Okay, so The sept means fusion protein. So whenever you get a sept, you are dealing with a fusion protein. A beta sept is a fusion protein which acts on a T cell and activate it. B cell, if you see, I have intentionally divided into Re, took, C, MAB. Now all of them mean something. This is how we name biological agent, and this will help you a lot in understanding it. It has a stem, which is at the end, that is MAB. It shows you what it is. MAB means monoclonal antibody. So the stem and the end tell you what the drug is. It's monoclonal antibody. Then the next substem, which is following it, it shows you the origin of it. In this case, it is Z, XY. That means it is chimeric. The third substem is the target. In this case, it's Q, which means it's tumor. TU is short for tumor. CI is short for cardiovascular. LI is short for the lymphocyte. NE is short for the nervous system, and so on, because I said that we use it everywhere. So in every system, you will be having a biological agent. So first stem is MAB. Next substem tell you how it is made. It's chimeric. I will tell you what chimeric is. The third substem is the target, TU, tumor. RI is a prefix, that is the name. Otherwise, all tuximab will be the same. Chimeric anti-tumor monoclonal antibody. So which one it is? A taqvim is Amjad taqvim, Athar taqvim, Arshad taqvim. So which taqvim you are dealing with? All are doctors. So you need a prefix to tell you. So the prefix in this case is Re. So the first will be prefix, forget it. It's just the name of the drug. So monoclonal antibody, which is chimeric and against the tumor. It's because against B cell, so naturally we can use it rheumatology also, but it was basically introduced as an anti-tumor drug. Then we have got anti-TNF. The first one is etanercept. Sept is again a fusion protein. End of the story. Then we have got infleximab. Again, I have divided intentionally. MAB is a stem, monoclonal antibody. Then a substem is Z, it's chimeric. Then a substem is Li, it's short for lymphocyte. And inf is a prefix. So I hope you are now getting the name. Then is sartolizumab. So again, the stem is MAB, monoclonal antibody. Zu is for humanized, Li is for lymphocyte. Sarto is this prefix. Then adalimumab. Again, you see, stem is MAB, it's a monoclonal antibody. Mu is human. Li is against lymphocytes, against immunity, and Ada is the prefix. So from this, we can get that we have got at least 3 types of biological agent: chimeric, humanized, and human. These are the 3. So one is as Z, one is as Zu, and the other is as M or Mu. So that will be the prefix used with them. There is a way to make them, you inject a TNF into a mouse. So against the TNF, an antibody is formed. If it's completely mouse, then it is called O, which is not used in a human because it will cause an anaphylactic reaction. So what they did was they removed every antibody is made up of 2 fragments, FC fragment and FAB, the antigen fragment. So the FC fragment was made human and the FAB fragment was left as a mouse. Then it becomes chimeric. It's 25% non-human. So even in that case, it will cause an anaphylactic reaction. Then they made it further modified, like Zu, humanized, not fully human, but humanized. So what they did was the FC segment, that is the human. The variable region, that is human, but the hypervariable region, the CDR1, 2, and 3, they were left the mouse. So 10% of it is still not human, and there was a hypersensitivity reaction to it. Then they go far and made a human one. The human one was made by 2 methods. One, they injected TNF and made a light chain, then injected TNF and made a heavy chain, joined them together and made a human lymphocyte. This was technically human, but actually not the way the human immunoglobulin is made. So that further resulted in a 40% allergic reaction. So in every case of the biological agent, one thing is common. They have allergic reaction, they develop antibodies, and ultimately stop working. Then interleukin-1 antagonist, anakinra, interleukin-6 antagonist, tocilizumab, that is Actemra, which we used a lot in COVID. Again, stem is MAB, substem is ZU, another substem is Li, and prefix is TOSI. So I think now you understand it. I don't need to go again into it. And interleukin-6, 17 antagonist. So that was main stem was MAB, substem again is U, that is mean human, and inflammation, IN for inflammation. Another substem is N, and C-Cook was the prefix. I hope you understand what stem, substem, and prefix means. So all the biological agents are named like that. T cell, A beta, CEP, B cell, rituximab, anti-TNF, I just summarized this here so that you have all of them present with you. Now, as they will suppress the immunity, so there are few things which are common to all of them. All the DMARDs, whether they are synthetic, whether they are biological, they will suppress your immune response. First thing they will do is they will cause the allergic reaction. They will lose their effect because antibodies will develop to them. Third, when you suppress the immunity, you cause reactivation of two major infections, tuberculosis and hepatitis B. Hepatitis C, once eradicated, is eradicated. Hepatitis B is practically never eradicated because it becomes part of your DNA. So when you suppress the immunity, you can activate tuberculosis, you can activate hepatitis B, and you can make the patient prone to severe infection, and that will be the risk you will always take and monitor the patient for them. And just like any other drug, you have to monitor them for the hepatotoxicity, nephrotoxicity, and bone marrow suppression. So the anaphylaxis, activation of tuberculosis, hepatitis B, and increased risk of infection is common to them. Each of them have their separate side effects, but that would be too long to cover. So I will just go with the summary. Now, why I'm interested in tofacitinib? Because we are conducting our own study on it. And we are 3 people, each of us have to collect 40 patients for at least 1 year and have follow-up and see what happens to them. So tofacitinib is JAK inhibitor. JAK means initially it meant just another kinase. Kinase is an intracellular enzyme system which causes phosphorylation of inactive enzyme, make them active. So it was initially meant just another kinase, JAK. Then it was found to be very interesting. The tofacitinib joined to receptor which joined to 2 kinases. So a Greek god named Janus is known for duality. It has 2 heads. It has the god in of start of 2 heads. So then it was changed to Janus associated kinase. And January, because it marks the end and beginning of something, is actually named after the Janus, which is a Greek god. The tofacitinib act via JAK state mechanism. Let's see what is JAK state mechanism. So multiple cytokines, including interleukin-6, they act on a receptor, the JAK state receptor, which joins, as we said, the Greek god, 2 JAKs, which activate the state. What is the state? Signal, transduction, and activator of transcription. So doesn't matter how hard the name is, it simply means it takes the signal, take it to DNA, and it results in the formation of the cytokines. So the end result is formation of cytokine. This system, as any other second mentioned system, is given a name, and that name is JAK state mechanism. The socks that you see are not the one which we wear. That simply means suppression of cytokine signal. So because the body is always having 2 types of things, one is activator and the other is suppressor to naturally control it. So when there is a JAK state activator, the sock is automatically activated to control it. But if there is inflammation, the activity overrides the control mechanism, results in a lot of the cytokines formation, and cytokines, as we see, promote inflammation, and in this case, causes the destruction of the synovial joint. Now, response to tofacitinib therapy, that's the 37 cases that I did. I have to do my 40 and the rest of them have to do their 40. It's a prospective study. It's an intervention because we are interfering with the outcome of the disease. And it is in a way multi-person, you can't call it multicentric. It's neither single blind, not double blind. It's of course not a placebo control. It's a very expensive drug, so we can't give a patient placebo. So it's not a category A study because a category A study should be double blind placebo controlled, which this is not. But at least it's multifocal and it's prospective. So we are seeing our own response, how we get it. In rheumatoid arthritis, we get the response by DAS score. Normally, the patient have more than 5.1 score. The partial responses, if it reduces to less than 3.2, between 3.2 to 5.1, and complete response is less than 3.2. DAS means disease activity score. 28 means we cover 28 joints. The 28 joints are the 20 joints which are present in the hand, and then the wrist, elbow, shoulder, and knee. So if you count them on the both sides, they become 28. You measure there how many of them are the tender, how many of them are the swollen, and you can have two ways to calculate it. One is if you are a mathematical genius like me. So you measure the tender joint, the swollen joints, and ESR and the general patient health. And you multiply the tender joint with 0.56 square root. You multiply the swollen joint by 0.28 square root. You multiply the ESR by 0.7, and you multiply the general growth of the general health of the patient with 0.014. So if you're a genius like me, you can do it every day on every patient in 1 minute. And if you're not a genius like me, what you can do is you can just simply download a mobile app which is called DAS calculator. I hope you can see it. This is the DAS calculator on my mobile, and you just open it, put the data in it, and it will calculate everything for you. So this is, one is a genius way, one is a smart way. I think follow the smart way and download it on your mobile. It's just a mobile app for Android and iOS both. So you can just download it and just put the tender joint, the swollen joint, whatever the ASR or CRP is, and gauge the patient general health from 1 to 10. And according to that, put it and get a DAS score. In our tofacitinib therapy, as you can see, we got at least some response. Like 20% have a very good response. Their DAS score got into the remission stage. 30% to 30 to 50% had a partial response. They were better than before, and 20% had no response. So for the moment, it's an ongoing study. One I can say is that in 70% of the patient, it has a partial or full response. So at least that is pretty good thing to do. The more better thing was that when we look into the side effects, apart from upper respiratory tract infection, mild allergic reaction, and some cases of elevated headache and cholesterol, we had no serious side effects, no bone marrow suppression, no hepatotoxicity, no renal failure. So it's pretty safe. And there is some anecdotal evidence. I'm hearing some nice.
Dr. Bashar, please turn off your mobile. वदीद इनको ऑफ कर दीजिए.
Okay, fine. I thought I'm very boring and you started talking. So anyway, so we got a very few serious side effects. And if you see that there is a full or partial response of 70% and a side effects of just an allergic reaction, a headache, and some upper respiratory tract infection, and just a raised cholesterol, so I'm willing to take a risk on it and use it because it's an oral also, not an injectable, and considered to the injectable biological agent, it is pretty cheap also. We have a lot of experience with Actemra also, but the Actemra study got interrupted in the middle because they started using it in COVID. We can use the tofacintinib with COVID also because it's the same mechanism of action of both of them. But that got interrupted in the middle because Actemra was very difficult to find. So we are now conducting this. Let's hope we complete it, and then I can give you a fully data. I hope that's it from my side. So if there is any question anywhere, I'm ready to answer.
So is that the end, Dr. Amjad Sahab?
Yes, that's
Are you
the end
finished
from
with
my
it? It
side.
was a lovely talk. It was great. But
I'm
I
finished.
have one question. How expensive is this drug?
That's probably,
Yes.
if you like to my patient, they are giving it at 8,000 rupees a month. But even then,
8,000
maximum price, full month course, but the maximum is probably 20,000.
20,000 for each cycle? And how frequently would this be
For full
repeated?
month, for full month course, it has to be taken lifelong. So because I have some pressure, my patients are more, my patient, they are giving it at 8,000 rupees a month. So 8,000 rupees a month is pretty reasonable nowadays. But the actual price is, I think, around 20. I don't know the exact price. But my patients are receiving it at 8,000 rupees a month.
Okay, okay. So the floor is open to any questions. Professor Rashid Saab, you have a question?
Yes, I have
Madam.
I have two questions at least.
Ek minute. Kaisar Saab is probably in a hurry and he wants to say something. Can we hold you, Dr.
Okay.
Rashid,
Oh,
and give the floor
yes,
to
yes,
Kaisar
sure,
Saab?
No,
Yes,
it's
sure,
okay.
yes,
No. Go on, Dr.
No.
Rashid Saab, please go on. मैं बाद में बात कर लेता हूँ, no problem. अभी I'm
नहीं,
here.
आप कल आपने जाना था, no issue.
अच्छा, मैं सिर्फ ये पूछ रहा हूँ कि अमजद साहब, it was a wonderful, excellent presentation. I would just would like to know when a patient with arthritis, severe arthritis, and as you said that the steroid is very important for them. If the patient is diabetic also, so what we do at this situation?
Put them on insulin, increase the dose of insulin, give them insulin on oral therapy both. There are 101 ways to control diabetes.
Okay,
I have never
fine.
found this problem because let's say he was previously controlled on 20 units of insulin, make it 40. So what difference does it make? Because for first year, the best disease-defying drug is steroids.
Yes. But sometimes we found that the people are coming without controlling the diabetes. They said that it's not controlled, and he or she having the severe pain, joint pain, and they are also very obese also. So how can one treat these type of patients?
The best drugs nowadays for obese diabetic patient is a combination of empagliflozin or any of that type, the SGLT2 type drug, whichever it may be, plus metformin, because the EMPA and metformin combination is very common, and that results in at least 5 kg of weight loss. So that helps you too. But again, as I said, what the steroids will do, that will cause insulin resistance. So you have to give an insulin sensitizer, and you have to give insulin and increase the dose of insulin. But diabetes should not be a contraindication because severely inflamed joints, you cannot control the disease-modifying drug, no matter how good they are not going to act really before 6 months. And your window, if you get a patient with, if the patient has already deformed joint, you can wait. But the maximum damage occurs in first year. And this is where you cannot take any slow steps. So you have to hit the patient with everything you have got. The earlier you get the patient, the more aggressive you should be. So diabetes should not be a contraindication to steroid therapy. And we can control diabetes. Every physician can. You have at least nowadays 100 options available. So that should not be a reason.
Okay,
Good. Thank you very
Kaisar
much.
Saab. Thank you, Amjad Saab. Now the floor goes to Rashid Mahmood Saab.
Right. Thank you, Dr. Amjad Takrim Saab, for an excellent and academic talk. I've got two questions at least. Number one, about CRP and ESR. Are they reliable markers to check the progress of the disease or treatment failure or treatment success? And second is the dose of the steroids. Has it to be started with full dose, or the dose depends upon severity? Less severe case, less dose, or more severe case, more dose. Is it like that? So
That's very good question. Okay, the immunosuppressive dose of steroid is different. The anti-inflammatory dose of steroid is different. In rheumatoid arthritis, we give anti-inflammatory dose of steroid, which is hardly 10 to 15 milligram. We don't need to go to 1 milligram per kg. That 1 milligram per kg dose is when you are using it for immunosuppression in myasthenia, in glomerulonephritis, in ITP. There you go for immunosuppression. Here we go for anti-inflammatory dose of steroid, which is 10 to 15 milligrams. So that is enough. You don't need to give a heavy dose of steroid. And the second was ESR and CRP. Of course, ESR and CRP, that shows you the degree of inflammation. The most sensitive test is basically the quantitative CRP. You know the exact how much it is and how much it has reduced. But because that is expensive, so we rely on ESR. But ESR is also a measure of disease activity. That's why it is in DAS score. Both CRP and ESR are present in DAS score, which measures the disease activity. So in rheumatoid arthritis, we measure the disease activity by number of tender joints, swollen joint, and their ESR and CRP, along with their general activity measure. Like in my case, I asked the patient that, okay, how is your NMAS doing? Can you do NMAS standing, DRQ, chair, and etc. So everybody has his own. So of course, CRP and ESR are for disease monitoring. But anti-inflammatory dose is very smart.
Thank you, Dr. Amjad, and thank you, Rashid Saab. We have Dr. Koshat Bharti with us. Dr. Saab, do you want to ask a question?
I don't have any question, but I'd just like to congratulate Professor Qasim for the excellent talk. I thoroughly enjoyed it. And maybe I just want to ask one thing. So the difference between XU and MU, MU is human and XU is humanized. Is that correct?
No. XI is chimeric. It's short for chimeric. Zoo, just remember animal. So it is humanized, not fully human. Mu or MU is human.
Human, okay, fine.
Okay,
human
thank you so much. Thank you for joining us. And now we have a question from Dr. Irfan Dean. What was the age range in this study, the tofacintinib study? The question is for you, Dr. Amjad.
Yes, please.
What was the age range in this study?
Oh, that was, I think I will have to publish it sometime. That included basically from 18 to 45. That every age group is present. It's almost in every age group it can start. So we wanted to include those who were not having a deformed joints, because in deformity you go for damage control. So the first thing was that their joint should not be totally deformed, because then it's basically damage control. We should get it in the first 2 years so that we have the maximum chance of remission. And the age group naturally had to be young, because they are living by age 60 with rheumatoid, they will be deformed anyways. I can give you a guess. I don't have exact data, but it's 18 to 45.
Thank you, Dr. Amjad. And there are no more questions. I just wanted to tell you, Professor Amjad Saab, that this has been taped and recorded, and then we upload it on our websites, and all our students listen to it. And anybody who wants to hear it again, like who have not joined us today, can hear it whenever they want to, because it is on the PMA website, the website of Mulazim Saab, website of Women Medical College. So this lecture has been saved forever and for God. Thank you so much for joining us today. It is always a pleasure listening to you. But
if it was good, send a copy to me also. If it wasn't good, so then don't send it to me a copy.
No, it was excellent. It was excellent. Of course, we'll send it and we'll save it. I think I'll ask Dr. Kesar
That's common courtesy. Nobody says to anybody that your lecture was not good. That's common courtesy. So I will actually want an honest opinion on that. And if it was good, then okay, then I will share with my student also.
Inshallah, we'll send it to you. We'll send it to you. And we do upload it. For the vote of thanks, I'll request Dr. Kesar Sajjad. It was so good that I think Kesar Sajjad has missed his meeting and he's still over here. So to Kesar Sajjad for a vote of thanks.
Okay, thank you very much, Dr. Salma, my dearest madam. Actually, it was excellent, very informative. I'm extremely thankful to Dr. Amjad Taqweem for presenting a very informative presentation today. And I also thankful to all the participants who have spared a valuable time on Sunday morning. That time is absolutely for the families. So I think they have learned today's more about the topic. I hope the next topic will be tomorrow, next Sunday. I hope everybody will join and more people will join. Thank you very much once again, Dr. Amjad, for your presence and presenting a very informative presentation. Thank you very much, all of you.
Jazakallah khair, Amjad Saab, and have a very good weekend. Everybody stay safe and enjoy yourselves. Allah Hafiz.
Thank you. Allah.
Osman Gul Saab has a question at the end: how to discourage depomedrol therapy in peripheries? Is Amjad Saab still around or has he left?
Why discourage it? I don't want to discourage depomedrol or decadran therapy at all. Why should I discourage it? That is my question. There is no need to discourage it because that is the therapy of rheumatoid arthritis. If you can't do anything, give them a depomedrol and send them to a rheumatologist. You have done something good.
Okay, great. So I think he has his answer.
Just educate them that it's a two-edged sword, and if you don't monitor it, you can damage the patient. As I said, steroids are like a knife. You can cut a throat with it, and you can cut a fruit with it. So it's up to you. So just educate them. But discouraging is a completely different thing because I can't ask you not to treat the pain of the patient. I just will give you a small story that one of in UK, my consultant had put the patient on everything: oral opium, subcut morphine, every damn painkiller, steroids, DMARDS. There were at least 25 drugs she was on. She was having systemic sclerosis. So I asked him, sir, what are you doing? Do you want to kill her? So he said, son, the only thing I can do for her is control her pain. Don't you want me to do that? And from then onward today, till now, I tell everybody, our job is to control pain. That's it. So whoever is controlling pain is okay from my side.
Like they say, one for the road. So the last question, and we'll not keep you after this, is when do you discontinue the therapy? There's a question in the chat box.
Okay, fine. That's because we have remission, basically 60% of the patients who are on synthetic and 40% of the patients who are on biological fail to respond somewhere along the line. Okay. And we only can discontinue the therapy hardly in 10 to 15% of the patient that they can go into remission. And that's also the spontaneous nature of the disease, that it relapses and it remits. So what you do is control the disease for 1 year. If the disease is controlled for 1 year with whatever therapy you are giving, the first thing to go should be steroid. The next thing should be NSAIDs. Like I said, SAID and SAID, DMARDS and PPI. So the first thing to go should be SAID. And if the patient is okay, the next thing to go should be NSAID. Then the third thing to go should be DMARD. And if the disease doesn't return, okay, fine. Then whenever the symptoms come back, the patient comes back to you. So, but at least you have to keep it controlled for an year, not before that.
Since the vote of thanks has been made, we will not keep you long. Thank you so much, Dr. Queen Sab. And I'm really, really grateful to you for this nice talk, and we all enjoyed it. There's still questions coming. So I don't know, maybe leave?
No,
or do you want
answer
to
them. I
answer?
still have time. I
Okay.
left the time basically for question answers.
Okay, fine. So somebody has a question. YO 1907, the name is not there and they want to ask a question. So you may please, Dr. Amjad is waiting for a question. YO 1907. Well, I don't know.
Please,
Probably he can't hear us. Anyway, Amjad Saab, we'll meet you next time, and I hope you give us another lecture on post-COVID, long COVID, in the coming few months. Would that be all right with you?
It's always, just give me 15 minutes.
Oh, great, great. Thank you so much. Allah bless you. Thank you. Allah
when you have no speaker, I should be your speaker.
Oh, great, great. That's such a good gesture. Allah bless you.
Okay,
Thank you.
fine. Thank
Allah
you.
Hafiz.